Hello, I'm State Representative Stephan Hay, and I'm here today with members of the Mass Nurses Association, and we're going to discuss their ongoing contract negotiations and safe staffing level questions and concerns that they have. We'll now allow them to introduce themselves. Ladies?
Good morning. I'm Natalie Pereira. I work at Leominster Hospital. I've been employed there for 34 years. I'm a med-surg nurse, and that's what I've been doing.
Hi, my name's Diane Lane Cormier. I'm an RN over at Leominster Hospital. I've been a nurse for 32 years, 18, almost 19 years now over at Leominster Hospital, and prior to that, 13 years out at Worcester Memorial Hospital. Thank you.
Recently, anybody living in the North County area has seen nurses at standouts all over the area. Explain to us and explain to the viewers why nurses are standing out and what the object is of the standouts.
Well, the nurses at Leominster, our contract expired in July of 2019, and we've been trying to negotiate a contract since then. We have been having difficulties with settling that contract out, and we've decided that it's time for the public to know what the hospital is expecting to get in the negotiations. So we need the public to know that the hospital has decided that they've proposed that nurses take 6 patients, that they eliminate our stat nurse role, which we'll get into that later, and that our charge nurses, who previously in our 2015 contract we had fought for and won the right for our charge nurses to not take assignments so that they can help us with the flow of the floor and to move patients through the system. They want the charge nurses to return to taking assignments, which will limit their ability to help anyone else.
Yeah, so these are huge takeaways from our contract, and we can discuss each one a little bit in detail for sure. But these takeaways really affect the safety of the care that we can give to our patients. And safety of our patients is priority number one. We fought very hard, like Natalie had said, about 5 years ago in a contract then to get all of these safe language, safe patient care language into the contract. And now they've decided that they're going to really come full force. They've drawn the line in the sand, and they've said, you know, we need these. We are going to take these away. We are not moving forward with this contract until we get these out of the contract.
Is the MMA offering alternatives in terms of those numbers in the negotiations?
Yes. We believe that they should maintain the charge nurse with no assignment. It's very beneficial, and it's very helpful in the flow of getting things through. You have nurses on a daily basis who unexpectedly run into crisis. A patient who was previously doing fine suddenly takes a turn for the worse. That charge nurse is able to come in and lend a pair of hands unencumbered by, well, I need to go take care of my own patients. The stat nurse, she's a med-surg stat nurse, and when the patient has gone past the ability of the floor nurse and the charge nurse, and we need another pair of hands who has a higher level of care, she can come in and begin that higher level of care prior to transferring the patient. They also think, and we think, that we did fight and win for a 5-patient limit, up to 5 patients per nurse on the med-surg units and foster wing. And we think that 5 at this point, with the acuity of these patients and that they come in sicker and sicker with multiple problems that we need to deal with, we think that at this point we can do 5, precarious at best, but we think that we should have 4. The patients for better outcome, and they get more RN patient-to-patient, hand-to-hand contact with the nurse versus I'm running around unable to care decently for each patient.
Right. So ultimately, you think 4 is the optimum number.
Right.
You're willing to do 5.
To stay at 5, correct.
And they're looking to push it 1 more to 6.
To 6.
Right.
So,
There's a lot of data out there that speaks to what is kind of a safe number for nurses, and the data proves over and over, and this has been for a long time, that 4 is a safe number. You start pushing up beyond that, you really start risking a lot of problems for patients. There's more readmissions, there are more very bad outcomes. So when we went to the negotiation table, our proposal when we first started was 4 patients. Theirs was 6, so we're trying to settle in the middle at the 5, which is what we have currently been carrying, and we know we can do it but we can also do it because we have a couple of the extra resources written into the contract, that being the charge nurse without an assignment, and that being the stat nurse. And the stat nurse, we'll talk about that a little bit, is a nurse with much more skills that she or he can go around to any place in the hospital and kind of decompress what's going on. Be a second pair of hands, be a second pair of skilled eyes to help when a patient is deteriorating, when their condition is changing for the worse. So if they eliminate those resources and take away the stat nurse and they force the charge nurse to have an assignment, even at 5, that is going to be a very significant struggle. And we know it because we've lived it. The hospital has really forced us into living with that already, and we see the bad outcomes.
So I'm not a math major, but is this correct? If you want 4 and they want to go to 6, that's a 50% increase. You're willing to take a 25% increase going to 5. 50% really puts you guys behind the 8 ball in terms of...
You did better math than us.
But really, it creates an environment that is unsafe for both the patient and, I would expect, the nurses themselves.
Correct.
And putting nurses in situations where they have to make decisions that is not in the patient's best interest, but because of the time constraint and the numbers that they have, means you're not doing what you would expect, the level of care that you'd like to give.
Currently on the floor that I work on, I take a 5-patient assignment every day without fail. I'm a 40-hour-a-week nurse, so 5 days a week I come in and I know I'm going to take 5 patients. Very early on in your report, while you're listening to the care that the other shifts have given to these patients, you start to decide, before you even get started, what are the things that I need to drop off my list of things to do to safely care for these patients. And if you're going to give me a 6th patient, it's almost, I can't do it. And then you start to wonder, okay, what am I going to miss? The key to being a great nurse and to being a good nurse is to be able to know your patient, walk in the room, make a quick assessment and decide something's different. They're not right. I need to keep an eye on this patient. But if you give me another patient, I don't have that time to keep coming back and saying, let me check your blood pressure again. Let's see how you're feeling. Let's talk to the doctor. Let's have a discussion. What they're asking us to do is unsafe. And as far as I'm concerned, it is unsafe. And to say to me, I want you to take a 6th patient, speaks volumes to the fact that they're not really looking at the person, the actual human being that's in the bed. Their motto is the heads in the beds. We just want people in the beds. We're not really concerned about how well or how poorly they're cared for. You know, so to me that speaks volumes. And to me, that's a patient, that's a human being, that's your mother, your father, your sister, your brother, your wife, your child.
I'm assuming that the term heads in the beds then equates to just dollar signs.
Yes, I'm sorry, yes.
That are coming back to
correct.
the administration.
Yes.
Quite a long time ago, hospitals, and it's not just Leominster Hospital, but many hospitals took on the lean process approach. And that was supposedly, you know, it came from the automotive industry. Toyota, I believe, started it, which is great for pieces of cars that you're putting together. We're talking about human lives, and you don't know which way they're going to go at any given moment. So they took this practice on, and they have leaned down that hospital to the bare bone. And it's not just nursing. We're talking about nursing today because we're at the bedside with the patients, and that's kind of the end game. But every department has been leaned down, and so it all has a ripple effect. I don't know if you got a chance to listen to the Leominster City Council meeting at all last night.
I was aware that everybody was there.
Right,
it was
right.
A good turnout from my understanding.
A good turnout, and again, you know, we talk about the ripple effect. They were very focused and concerned about what kind of strain it would put on the city, the EMS services, police services, all of that. But I'm telling you that if we can't manage the patients on the floors because we don't have enough staff to do it safely, it creates a huge logjam, which eventually gets down to the emergency room. They've got no beds or nurses able to move those patients up, and it puts a huge strain.
I was going to ask you about that. One of the things that I was hearing from the standouts was that they were looking to downsize the number of nurses in the emergency room. which seems to me a very dangerous thing in today's environment, where unfortunately too many people use the emergency room as their primary care, and too many people are at the emergency room with mental health issues and all of those types of things. Is that part of your negotiations also? Is that something that you see happening from the administration?
Correct. Well, currently the emergency room is in the middle of a reduction in force. 4 years ago, we met with the hospital and they said, we're going to build a bigger emergency room. We need, because we're going to have, our volumes are going up and we need more room. So they started this phases of building a bigger emergency room. And we increased staff at that time. And now 4 years later, 5 years later, now they're saying your volumes are down, we don't need as many nurses, so we're going to eliminate some positions. Well, the problem with that, and also part of their proposal for our contract, is to eliminate the number of 5 for the emergency room. There is no number, there's no cap. So the fear that us nurses have, we all have, is I could be an emergency department nurse and I could already have 5 patients and then be told, well, you can take 2 more or 3 more or 4 more. And where does it stop? There is no cap. So I could be taking care of 10.
So are they unwilling to put a number in the emergency room?
Currently now, we are all capped at 5, up to 5 patients, including the emergency room. Their proposal states the floor nurses will take 6 and there is no number for the emergency department. So that the implication there is it could be 6, it could be 7.
Yeah. They're afraid that what that equates to is we're stopping people coming in from the door, in through the doors, which is absolutely incorrect. There's a law that prevents us from doing that. Patients still have to come in. They still have to be triaged. So they will take the most sickest or critically ill. They prioritize, and they will take them first. And while they're working on them, they have a number of 5. Once they've got them settled, they start to move them out, and they take more in. So there's no stopping and closing the doors. But it does give us some safeguards to them saying, all right, here's your 10th patient. And those 5 patients that they currently have, they could essentially be all critically ill patients that once they get to the ICU, they're going to be managed as a 1-to-1 or at the most a 1-to-2 ratio at the very most. And they might have several others like that. So it makes no sense to say that there shouldn't be some sort of cap on there. Obviously, again, a trauma comes through, something urgent, they'll push them to the front of the line. They're going to get seen.
Right. Well, it must also be frustrating. It seems a little awkward to me that they wanted to expand the physical space of their emergency room and spend millions of dollars, I assume, doing that, to then decrease the number of staffing that they have in that space. Seemed to me as if you're expanding space, you should be expanding the amount of staffing, not decreasing it. Now, so they just have empty space that's not being utilized.
Correct. Not a lot of forward thinking there. And I will say, you're never going to stop the communities from using the emergency department as their primary health care. We are not a rich community. So yes, and we have a shortage of physicians, primary care physicians, and it's coming, and it's going to get worse. They're going to, doctors are leaving, they're retiring, etc. So yes, people are going to have nowhere else to go but our emergency department. And so what are you going to say to them? You can't come? And we don't have physical nurses to take care of them. It's all well and good to come into our emergency department, but if there's not enough nurses to care for them, you're gonna sit. And then that's the problem. Everyone complains about wait times. We gotta wait. As I say to everybody, people are waiting in the emergency room. They're called boarders. They wait in the emergency room to get admitted to a floor. Not even an ICU, because we have ICU issues as well, intensive care. To get admitted to the floor. Our floors are both full. Most of the time, 98% of the time, we are full to capacity. We can't put them in the hallway. But yet we have a whole entire 15-bed unit closed that could take some of these patients from the emergency room.
Yeah.
But we don't have the staff to open, and they have reduced us to the point where it's a closed floor.
Right.
And so there they are in the emergency room waiting, taking up emergency department beds with med-surg admissions.
Right.
So
they have created the flow problem by constantly cutting departments and decreasing nurses. So I mean, for us, the contract dispute right now that we're in, and why we are out in the community and everything, is trying to educate them as to what's going on. And again, it's the big three for us. It's the going up to the 6th patient, which we find really not doable in any kind of safe manner at all. It's taking away our charge nurses, which, you know, we get new nurses in, and they heavily rely on a resource person in the beginning, because you don't come out knowing everything you need to know. You may not have been exposed to it in nursing school. You may not even be exposed to it in the first few years. And so you need a seasoned kind of veteran that's your resource person.
You need some time to have a mentor.
A mentor, and to be able to do that. And again, we've already had to live through that. We've been pushed to trying to take charge with an assignment, and it doesn't work. It's not safe.
But prior to the 2015 contract, the charge nurses were taking assignments. And when we came to negotiations in 2015, there was a very strong feeling that we need to have a charge nurse that does not have an assignment. These patients are getting sicker. We get them in and they have multiple problems that we need to deal with. And we fought long and hard for that. And so we're going to fight long and hard to maintain it. And that's why we're out in the community. The community needs to know this is our hospital. I live here. I go to that hospital. And the community needs to know. You'd be surprised at how many people have no idea that there's going to be a reduction in force in the emergency department, that they're going to reduce the number of nurses in there, and everyone asked the same exact question you've asked. So you're building a bigger emergency room to reduce the staff. That doesn't make any sense. The number of people, like at the city council meetings, both Leominster and Fitchburg, everybody had the same question. Everybody's going to Worcester. They're being shipped to Worcester. They're going to Worcester. They're going to Worcester. So are they going to reduce our hospital to what? Who knows? I mean, we want our community people to come to our hospital. But if
we want to continue to have a community
and we
hospital
want to continue to have
instead
a
of
community
everybody
hospital.
going to Worcester for everything.
Right, and we believe that the communities need to know, and they need to make calls. They need to sign our petition. They need to sign the petition that they want to maintain our resources here and keep our hospital open, keep an emergency department, keep an ICU, keep med-surg floors, and bring more things to us, because they're eliminating stuff. So we have petitions. We're out on standing on the sidewalks, having people go to make phone calls, and we're going to be doing leafleting. There is so much more that's coming up, because we believe that we need to take this fight to the streets, because it isn't a dirty little secret. We need the communities to know and complain vehemently and say, you know, stop the cuts, stop it. This is crazy. This is unacceptable. And we are your constituents. We are your customers, as they like to call them. We are your customers, and we're saying no. Enough is enough, and that's how we feel this strongly. We are not actresses. We don't like coming and sitting in, but we feel this is how driven we are, that we're out on the sidewalks, that we're out doing things, doing public appearances, doing interviews, writing letters to the editors. Anything that the community can do to help us, we need their help. That's why we're here.
Recently, I did see in the newspaper that the CEO of the hospital, Steve Roach, spoke about the respect and support that they have for the nurses. But did management ask the bedside nurses for input regarding eliminating the stat nurse role and the change in the assignments, or is that just something that they decided?
They make those decisions behind closed doors. And sometimes we can't even understand what logic they're using when they make these decisions, honestly. But no, as far as the stat nurse role and eliminating that, we asked them, who did you discuss this with? How did you come up, you know, with this idea that it wasn't a valuable role? They said they hadn't asked anybody. So we actually took our own survey, and we came up with 300 signatures or better. Losing my voice from allergies, yeah.
From hospital employees, from nurses, from non-nursing staff, from ancillary staff, CNAs, secretaries, security guards, dietary. You know, we asked everyone, and they're like, yes, you do need them. We see what they can do. So, you know, a lot of their stuff is based on, I don't know what. We would have to ask him He certainly is not from around here. He does not use our hospital as his primary source of care. He is short-term. He just got here. So I'm not really sure he's had time to get a lay of the land and figure out what needs to be done. But these asks that they're putting across the table, these proposals, are proposals that we can't tolerate, and we need the community help.
I would think that, if you're going to make a suggestion regarding getting rid of the stat nurse, you would talk to the people who are in the trenches doing the day-to-day work, and how's that going to affect them, affect their ability to give good care to the patients. And it seems like this is being made on a different level.
It's been extremely valuable. And even, I'm going to lose my train of thought here again. It has been a very valuable position. And even to the point, this is what I was going to get to, was that they have written the stat nurses into many policies now. And it, again, makes no sense. They come to the table and say, we want to take this away. In the same breath, they are writing new policies that say the stat nurse will do this. The stat nurse will intervene here. So it's hugely valuable to our patients, to our nurses. We talk a little bit about the numbers, and 4 is the number that data bears out, that's how many patients a nurse should take. CEOs, administrators will talk about how reimbursements from Medicare and everything the insurance companies have gone down over the years, and that's put a big stress on their budgets. But also, they're related to how well you're giving care. They go up if you keep patients out, with certain diagnoses, that you don't have multiple readmissions for those. They're doing patient surveys all the time, Press Ganey's. And so a lot of their reimbursements are based on this stuff, yet they want to staff you with the minimum staff to perform that work.
Which is counterproductive.
It's counterproductive.
To their reimbursements going up.
Right. I keep talking about we need CEOs now that are forward thinking, that really look at how can we bring more money into the system. Enough with the cuts. We're at the bare bone. There actually is an end game to that where you can cut too much. And we're there. So they need to be a little bit more creative, out of the box thinking to bring in some more money, resources.
I'm going to assume when we talk about the stat nurse and them not asking anybody about it, it was the same thing with the charge nurse.
Oh, absolutely.
They did not come in and ask what effect this has and what this person does and what the fallout will be if that person's gone.
Correct. And the problem is that the people that are making the decisions are not bedside nurses.
No.
Some of them don't even have licenses. They just got this job. So the problem is you first need to understand what we do. It is not I'm only going to allot you 6 minutes. It doesn't matter what's wrong with you, you get 6 minutes. That doesn't work. When you have a dying patient.
That scares me.
Yes.
Yeah.
Yes.
Yeah.
And when you have a dying patient and a family and people who just don't understand what's going on, it's not just the head in the bed. It is the person that's laying in that bed and their spouse, their mother, their father,
family.
their sister, their brother, their aunt, their uncle, the 25 people who care for this person, who it's an important part of their lives. It's not just the person in the bed. You get the multiple phone calls from family members, you get the people coming in to visit, you get all the questions from them, then you need to care for the patient. And to say, I'm gonna, you get 5 minutes and that's it, is just not acceptable. It's not nursing. It is not.
You need your nurses to have the time to have their eyes on what's going on. A lot of people don't see what nurses do behind the scenes, but we're constantly looking at data, we're looking at labs, we're looking at vital signs, we're assessing our patients, and we're in constant communication between the patient, the family members, the doctors, and any other support staff that we need in order to pull all of that team together to give high quality safe care to our patients. So,
And in your attempts to give that high quality, safe care to your patients and doing all of those things behind the scenes that
Yeah.
we don't see, but you are doing every minute of every
Yes.
day, of every shift, I'm going to assume, but I will ask the question, with the increase in the number of mental health patients that come into the hospital on a daily basis, that must make that even more difficult and stretch you even thinner.
Correct.
yeah,
It does.
It strains the system greatly.
It does. And, you know, at the city council meeting, you know, Mike Kuzmarek, who said, you know, they made
was-
promises
that's the
to us.
Fitchburg City Council.
The
Yes.
Fitchburg one. You know, they made us promises when they closed Burbank. They made promises. They said, oh, you'll always have an urgent care here. Oh, you'll always have mental health here. And then look at, oh, now we closed urgent care. Oh, now we've closed mental health. But we're going to designate areas for the mental health patients to go to. And as some of the nurses testified, you know, they have a 7-bed, 8-bed area for mental health, but a lot of times it's more than 8. So it's they're out into the emergency department, taking up space in beds. And we have a sore lacking of mental health providers and places for them to go. So they gave us our mental health area, and then when they closed pediatrics, we'll have a designated area for the pediatric patients to come. It still hasn't come. We don't have a designated area for the pediatric patients, but they promised us that. So I think that the communities need to know that, yes, they do make promises, but they don't really follow through.
And that has an adverse effect on the
Yes.
patients and the care that you folks can
Yes.
give.
Yeah, once again, it's all the trickle effect. So there's a strain starting in the ED with the mental health coming in.
Yep.
That goes out to the floors. And honestly, we can have a mental health patient, a couple of them on our assignment, and if they're in crisis, we need to deal with that sometimes before we can deal with our other patients, because it's just that bad.
Yeah.
So it is a strain.
Well, it sounds like you folks have a lot of work that you do in trying to bring quality care to the patients that are in the hospital. People who are listening today, I hope are understanding what you're up against and what you're trying to do. And how can they help you in this decision or this battle, whatever word you want to use, that you're having with the administration in terms of keeping the safe staffing limits and to provide quality care for the folks who visit your hospitals. What could they do?
Well, currently, we have a petition that we need people to sign. We have paper copies as well as it's online. You can go online, and I think they're going to put it on along the bottom of the
screen.
the
Yep.
scroll. You can certainly write letters to the editor, letters to anyone that you may know that might have some influence on their decision making, because as we've said and tried to impart, we don't have a lot of input into the decisions that they make. We're under the UMass umbrella, and I think sometimes some of the decisions that are made in Worcester, and it needs to be carried out here, and we are a small community hospital, and that's the way we want to stay. You know, we devote our time to taking care of patients. The nurses who are working, a lot of them are picking up extra shifts because they don't want their coworkers to have to work with not enough staff on or with less staff than is appropriate. A lot of us bypass our lunch, bypass our breaks. A lot of times we stay late. Many times we stay late. And everybody says, oh, it's just to get the overtime. No, it isn't. We all want to go home. We all have families, we all have things to do. Nobody wants to be there, 1 hour later than usual because we've pushed everything to take care of the patient. We do all the stuff that we can push off to the end to take care of the patient. So certainly letters to the editor, petitions, we'll be doing leafleting.
Right, and there'll be more to come too.
And there
You
will
need to
be
kind
more.
of pay attention to what's going on because this is far from over.
Yep.
I know we have a couple of thank yous too because we're very grateful for having this platform to be able to get the information out to the public. We both have our matching M&A shirts on, but I wear that sometimes is a negative connotation with unions. I don't have that. I'm very, very, very grateful that we have a strong M&A union in the hospital because they bring us to the table. They give us a place at the table with a protected voice. And not all hospitals have that. If you're in a non-union hospital setting, you don't have that. So I always have to give my kudos and thanks to them for helping us, get this information out, because it's really important.
And also to you for allowing us this venue to get our word out to the community. I'm sure it's a very popular television station.
Well, I can tell you, I'm very appreciative of the opportunity to be here today with the nurses from the MMA, and I hope that the folks who are listening and watching this understand how important this is. We want to keep a community hospital in our community, and we want safe staffing levels, and we want these hard-working, diligent nurses to get the contract that they deserve. So,
and yes, and we believe that all we want to do is take care of our patients. You'll never hear anything from us as long as we're allowed to take care of our patients safely. I would also like to congratulate you on your upcoming retirement. I'm very jealous.
Thank you. Thank you very much.
Thank you for your years of service to the city and to the community, and for giving us a venue to be able to speak our mind.
Certainly appreciate it.
Yeah,
and folks out there, pay attention. There's ways that you can assist these nurses. Thank you.
Thank you.